Very good evening, friends. Now you are watching Surgical Educator RKT. Today we are discussing about pancreatitis because we all know pancreatitis is a very serious type of infection. Mortality rate in case of severe infective necrotizing pancreatitis more than 60 to 70%. So at the time of admission, we have to assess the severity of the illness by different scoring system. Most common score we are using is a Ranson score. Disadvantage of Ranson score is that assessment of the severity of pancreatitis requires more than 48 hours. First we score at the time of admission, and second we reassess the patient after 48 hours. So for the know the severity of the illness and what is the prognosis, the outcome of the disease, it takes 48 hours to decide. In Ranson score, at the time of admission, first point, age more than 55 years, TLC counts more than 16,000, AST, SGOT more than 250 units per liter, LDH more than 350 unit per liter, random blood sugar more than 200 milligram per deciliter, and partial pressure of oxygen less than 60%, and serum calcium level less than 8 milligram per deciliter. And after 48 hours we reassess the patient in certain parameter. Point number 1, in case of pancreatitis, hemolytic rate reduction more than 10%, blood urea nitrogen BUN more than 5 milligram per deciliter, base deficit more than 4 milliequivalent per liter, SGOT and LDH more than 600 unit per liter. These, if score more than 3, is indicative of bad prognosis. So we have to explain the prognosis of the disease to the patient party, and according to parameter we have to manage pancreatitis. In case of mild pancreatitis, we can treat the patient in ward or high dependency unit. In case of severe pancreatitis, ICU admission must. Now there is a certain score like Balthazar grade, Apache 2 score for assessment of the pancreatitis. We all know pancreas is a retroperitoneal organ, so CECT is the gold standard and investigation of choice to assess severity, extent of the disease. So there is CT severity index equal to Balthazar grade plus necrosis score. Now we briefly discussing about Balthazar grade. Balthazar grade, if CT is grade 1, grade A, if CT scan finding are normal. Grade B, if there is a focal or diffuse enlargement of pancreas. Grade C, there is a distortion of pancreas, destruction of pancreatic tissue or peripancreatic collection is the grade C. Grade D, distorted pancreas and fluid collection, acute fluid collection in a single location. And grade E, when the fluid collection more than 2 location or there is a presence of gas bubble adjacent to the pancreas gland. It is the indicative of very severe form of necrotizing pancreatitis. Now there is a certain complication of pancreatitis, because in case of severe form of pancreatitis there is a cytokinin storm. So each and every system system of the body is involved. CVS, there is a hypotension, vasodilation, tachycardia, pallor, and respiratory system difficulty in breathing due to presence of pleural effusion in 20% cases. First pleural effusion appears on the right side, then bilateral. Presence of ascites. If the patient having ascites, in case of pancreatitis, we aspirate the fluid, and then after analysis of the fluid, this is the amylase rich fluid. This is the indicative of the ascites due to pancreatitis, not other cause. So we have to check amylase activity in the ascitic juice. GIT, in case of inflammation, there is a ileus presents, bowel sound plus minus or mild sluggish peristalsis present. In case of hematological, DIC is very common. Disseminated intravascular coagulation is the complication of pancreatitis. And CNS, confusion and irritability, and sometimes patient unconscious in case of severe pancreatitis. So we have to treat patient of severe pancreatitis in intensive care unit only. In a care for monitoring all the vitals by the critical care experts. And there are some local complications. First is the fluid collection. Mostly 60 to 70% fluid collection in case of pancreatitis resolve spontaneously within 4 to 5 weeks. If fluid collection remains more than 4 weeks, and there is this formation of the pseudocyst. Pseudocyst is the collection of the fluid in the laser sac, most common site, in the stomach bed, and covered with a wall, but pseudocyst not having a epithelial lining. Wall composed of pseudocyst of granulation tissue and fibrous tissue only. No epithelial lining in the pseudocyst of pancreas. Pancreatic abscess. In case of fluid collection, there is infection. Pancreatic abscess present. Percutaneous CT guided aspiration of the abscess mandatory. In the severe form of the pancreatitis, there is a necrosis of the pancreas. Type of necrosis, there are two types of necrosis. First is sterile necrosis. Second one is a infected necrosis. In case of infected necrosis, surgical excision of the necrosed part of the pancreas mandatory after stabilizing the patient. In next video, we are discussing about management of pancreatitis medically and surgical. After that, we are discussing pancreatic tumor and palliative treatment of pancreatic carcinoma, because at the time of diagnosis, mostly it is found that mostly pancreatic tumor is unresectable. So later on we have to discuss, because it is a very important chapter, so we have to discuss in a small segment only. Thank you for watching. Please comment.